Hello, this is Dr. Bernstein with your March 2018 teleseminar. Before we begin, I want to give you the usual caveats. My answers to the questions are generic answers. They're not necessarily geared to the individual who asked the question because I haven't done a physical exam or taken a complete history on that person. Furthermore, these answers are meant for the general listening population and are meant to be educational in general, not necessarily geared to the person's particular problem, which may be very unique. One other thing I want to point out is that we are now getting bombed with problems posed by people who have been ensnared by the latest ketogenic diet craze, where they're deliberately adding fats and oils to their diet and taking away carbohydrate, which is okay up to a point, but also taking away protein. And they're causing considerable damage to the patients, especially to children. Children need a lot of protein. I've had questions from people saying that they read that humans should only receive 1 gram of protein per kilogram of body weight, and that applies to invalids who cannot move around and are confined to one spot all day long. That number does not apply to people who have physical activity, who commute to work, who walk around a house, and certainly not to children who may need many-fold that number in order to grow. Athletes certainly need many-fold that number. So there are these myths going around, people are being injured, and they're boasting that they're on a low-carb or ketogenic diet, but it's really a diet depriving them of protein. Okay, we'll get now down to the questions. First question, what are your thoughts on bitter melon caps? Bitter melon is a vegetable that looks like a cucumber. It has considerable toxicity to it, depending upon the part of the vegetable that you consume. I understand that the pimples on it are toxic and dangerous to children. It's been used in ancient times to treat diabetes, but the efficacy is very questionable, and the big risk is that it may be mixed with pesticides or with other substances and could be associated with toxicity. Is monk fruit juice concentrate acceptable as a sweetener? Absolutely not. It contains a lot of sugar. That's why it's sweet. Is the size of an insulin unit universal? For instance, are units as measured on syringes equal to those delivered from insulin pens? Well, it probably depends upon the pen. There may be problems since there's so many being made nowadays. One wonders who's inspecting them. Does the FDA approve pens based upon their own inspection of the pens, or is it based upon the manufacturer's claims as to what the units say on the pens? The unit is supposed to be universal. However, there are some downright lies that have been going on for years. For example, a unit of Lystro or Humalog insulin, for most of us, is twice as potent as a unit of regular or crystalline insulin. A unit of Novolog insulin is about 50% more potent than a unit of regular insulin, which Novo calls Humulin R. So there are deceptions going on with regard to the new analog insulins like Humalog, Novolog, etc. And what can be done about this is just to be aware of it. "16 years old, diagnosed at age 11. For the past 2 weeks, I have depression. My blood sugar is always elevated. I am scared. I feel like I was poisoned. Did you ever experience depression and hopelessness?" Well, I experienced it in the old days before I invented blood sugar self-monitoring. I never knew what my blood sugars were. And once I got my first blood sugar meter, I saw that they were oscillating between near zero and 1,500 milligram per deciliter. So no wonder I was depressed. When I did a research study, actually I did 2 studies, long before I became a physician, one at Rockefeller University, one at Downstate University in New York. And we, because the doctors who donated the patients to us, they donated what they considered were their worst patients, said that my regimen would drive them crazy. We did depression testing before and after they learned how to normalize their blood sugars. And we applied the Hamilton Depression Score. On one group, we had them interviewed by a psychiatrist, and the other group was a psychologist. And both groups were found to be severely depressed when we started with them, and depression score vanished to 0 when after they learned how to control their own blood sugars. So it is expected to find people who are depressed whose blood sugars are jumping around erratically, and once they learn how to control their blood sugars, the depression seems to go away. And the most common expression that I found when I interviewed the people afterward was, now I'm captain of my own ship. My blood sugars are not varying at random. My 16-year-old son was just diagnosed a week ago, and I'm trying to lower his carb in each meal. Do you recommend lowering it gradually or quickly? Well, as I've told my listeners in the past, I ordinarily don't answer questions that are already answered in my book, but sometimes I make exceptions, and this is an exception. I'll have to reiterate what the book says, that if you try to gradually lower the carbohydrate consumption, you're just perpetuating the carbohydrate addiction, and it becomes very hard to accomplish. In fact, I don't know of anyone who's successfully lowered their carbohydrate intake gradually. They inevitably fail. So you have to do it suddenly, all at once, and then it takes about 2 weeks for most people to lose their addiction. Now, not everyone loses their addiction, and for the people who don't, we have tricks that are discussed in my book, Diabetes Solution. My 9-year-old son was on insulin for about 3 weeks. He kept running low, eventually stopped the insulin. Low-carb diet made his numbers drop. C-peptide is now positive. That means he's making insulin. A1C is 4.8. How long can we expect his pancreas to continue producing? Very good question. The answer is that we really don't know. We do know that glucose high blood sugars, I should say, are toxic to the beta cells of the pancreas. I have a number of patients who have kept producing insulin for many, many years. I guess the longest is 27 years. A patient whom I diagnosed 27 years ago, she had a type 1 sister, and I diagnosed her at age 40, shortly after she became symptomatic, and put her on a very low carb diet, put her on insulin, but we stabilized her after about a month or so at about half the amount of insulin that a non-diabetic her size makes. And she's still at that same dose 27 years later. And we have other cases that are similar. So it could last a long time if you really keep blood sugars normal. My feet get extremely hot at night to the point of discomfort. Why, and how can I soothe them? Well, feeling something that isn't there is called a paresthesia. If you were to ask someone else to feel your feet and they didn't feel hot to the other person, you're feeling something that is not there. And that could be caused by high blood sugars. So one possibility is to normalize your blood sugars, and usually the neuropathies of the feet disappear within a few months. There's one other possibility, and that is if you have what's called ischemic pain, pain due to poor circulation in the feet. And this burning feeling sometimes occurs in people with poor circulation in their feet. And one quick test of this would be to put 6 by 6 inch timbers or blocks under the bedposts at the head of the bed so that your feet are lower than your heart. That would improve the circulation to your feet. And if the pain goes or the burning goes away when the head of your bed is raised, then you know it's ischemic pain, and you know the solution is to raise the head of the bed. There are other things that can be done if you have ischemic pain. For example, exercises involving toe presses, or if you have stairs in your home, heel raises, doing this many times over the course of a day, improves the circulation of the feet, but only if your blood sugars are kept normal. Another thing is L-arginine, 2 grams per day, can improve the circulation to the feet. So that, combined with the exercise, combined with normal blood sugars, can be effective. After binge eating, my glucose level was 519. I got so scared. It woke me up, and now I am back on track. I have followed Dr. Bernstein's program before, and it worked for me. Is it too late? Can I ever get back to where I was before I began this binge? If I follow his program to the letter, will it work, or am I doomed at this point? Well, it always helps to normalize blood sugars. And the game plan, of course, is to keep them normal all the time. And this is all disclosed in the book. How to stop you from binging. We have some hints in the book that you might. Just diagnosed with type 1 diabetes at the age of 53 in a bad car accident 2 weeks prior. Could the stress of the accident have caused diabetes? I've seen many cases of this. I shouldn't say many, but a number of cases where, in all likelihood, the patient was on the verge of having high blood sugars, probably had lost close to 80% of their beta cells, and then a stressful event comes and they go over the hill and start showing the high blood sugars. So this is not uncommon. It does happen from time to time, and you can believe that it's likely to be the case. I've been a type 1 diabetic for 38 years when I developed type 2 diabetes. Now, in addition to having an insulin pump, I also take 500 milligrams of Metformin twice a day. I would like to know why I lose weight as a type 1 with high blood sugars, but as a type 2 with high blood sugars, I gain weight. Well, in my experience, the type 2 occurs because of the weight gain. You become insulin resistant. And in fact, there is now an epidemic of type 2 diabetes affecting type 1 children who are fed high carbohydrate diets. So here this person was on an insulin pump. The insulin pump usually is set to give a much too high a dose of basal insulin, forcing the patients to eat more. They get fat, and then they develop type 2 diabetes on top of the type 1 diabetes. Please discuss Admelog by Sanofi. Since it functions similarly to Humalog, I assume you would not recommend it for anything other than bringing down an out-of-range blood sugar quickly. Is the action more similar to Humalog than to Novolog? It's coming out soon. Apparently it's been approved in the USA by the FDA, and it's apparently identical to Humalog, not to Novolog. And the only time I recommend these rapid-acting, super potent insulins is for people who are severely insulin resistant, usually obese people, where we want to get a blood sugar down rapidly. I do have a few very obese type 2 diabetics who need a small dose of Humalog on arising in the morning to fight the dawn phenomenon. So that's an interesting special situation. Should I apply the formula from your book for converting A1C values to blood sugar, to average blood sugar, when I use the A1C Now test kit? Well, in my experience, the A1C Now test kit is not very accurate. So whatever formula you apply is likely to come out with an incorrect answer, since the A1C is likely to be incorrect. The test kit is also highly dependent upon the user. It requires you to fill a capillary tube to a certain mark, etc., and it requires a great deal of skill. So I don't advise you to use this system. You should, if you're interested in A1Cs, you can get the blood drawn through Quest, LabCorp, or another national clinical laboratory. I'm trying to think whether there are other, yeah. The other bit of advice I would give is go by blood sugars, not by A1Cs. But that requires that you sometimes get blood sugars in the middle of the night, because if you skip the nighttime blood sugars, you're going to miss some important information. Should supplementation with vitamin C be avoided in diabetics because of concerns that it elevates blood sugars? Well, it can also be a substrate for producing oxalate, which is the main component of kidney stones, of calcium oxalate kidney stones. Very high doses of vitamin C have been associated with malignancies. So there are reasons not to take large doses of vitamin C. The only reason for taking vitamin C would be if you're deprived in your diet, and one way to find this out would be to have your doctor check your serum vitamin C level and see what it turns out to be. But in general, because of the, and also large doses, by the way, destroy the enzyme in the blood sugar test strip, so you won't get accurate blood sugar readings. So unless you have low serum vitamin C levels, there's no reason to take vitamin C supplementation. Type 1 for 28 years. Started your diet. My B12 blood tests for 3 years are high, 2,000 and above, even though I don't take B12 supplement. Any explanation, please? You might want to see a hematologist. It's not a result of the diet, I'm sure, and I imagine that your B12 was elevated before you switched the diet. There are congenital situations that can result in an elevated serum B12, and there are some strange blood dyscrasias associated with diabetes, such as the CVID that we discuss in my book. So you probably should see a hematologist. Type 1 diabetic for 3 years. Read your book. How do you know whether to use Tresiba twice daily and how to dose at morning and at night? I find that one nightly dose of 4 units keeps me stable throughout the night and day. Well, it's trial and error. And I'm willing to bet that if you're taking only 4 units and it keeps you stable for 24 hours, that you're probably making some insulin of your own. And you could find that out by checking your C-peptide at a time when your blood sugar is above normal. So if you take a little glucose to get your blood sugar, let's say up to 120, and then go to the lab and get a serum C-peptide level, if you're still making insulin, it'll show up. That's my guess. Now, what we recommend in my book is that you take it twice a day, because most people need it twice a day, but that you do it by trial and error. It's there. We may not mention Tresiba in the book because it's a newer insulin, but we mention it for Levemir, and in older books we mentioned it for ultralenti insulin. So although it's twice a day for most, and I might repeat, because I've said this before, I have to take my Tresiba at bedtime and then about 3 hours before I get up in the morning. So it's an oddball timing and inconvenient, but that's what I find is necessary. And many full type 1s have to do the same thing, even though this is the longest acting insulin we have. What are the key tests for for differentiating type 1 and type 2 diabetes. Is it possible that a person with anti-GAD and anti-insulin antibodies, both negative, to be having type 1? Yes, there are the usual tests, research tests, to see if you're making antibodies that might predispose you to type 1 diabetes, are GAD, which is a protein on the outside of the vesicles that contain insulin granules just prior to their bursting to release insulin into the bloodstream. And then anti-insulin antibodies. Those are the most common ones. But there are many antibodies that are associated with type 1 diabetes. And there are even antibodies associated with type 2. It's very complicated. And probably every few months, new antibodies are being discovered. So it's not a simple thing. And digging to see whether you're type 1 or type 2 can be frivolous, because whatever kind of diabetes you have, you want to control your blood sugars. And what's important is what works. As Yogi Berra told me, what works, works. So trying to give it a name is not the important thing. The important thing is a treatment that keeps blood sugars normal. Okay. What are the newest insulin sensitizing and insulin mimetic agents, and how effective are they? Well, I'm trying to think. This question is not asking about the GLP-1 agonists. It's asking about insulin sensitizers and insulin mimetic agents. Well, insulin sensitizers would be limited to 3 drugs that have been on the market a long time: Avandia, Actos, and glucophage, or Metformin. Avandia is rosiglitazone, Actos is pioglitazone, and then there's Metformin. And insulin mimetic agents are the sulfonylureas, and there's a new group that are similar to sulfonylureas, but I don't recommend using those because, well, they're not really insulin mimetic. They cause beta cells to make more insulin and foster beta cell burnout. So there's really nothing new that makes sense to take. There's a new GLP-1 agonist that supposedly lasts for a week, means 1 shot per week. And I'm experimenting with it on people who are taking GLP-1 agonists to control overeating. The trouble with the new one is that it's going to be stimulating GLP-1 receptors all week long, and I suspect that this might cause the more rapid development of a tolerance to the medication. So I'm experimenting with it to see if it does that. What do you think of some of the newer over-the-counter products on the market? PGX Fiber seems to have helped me. Well, the fiber products probably help because they make you feel full and curb overeating. There are some fiber products that foster proliferation of the microbiome, and the microbiome is a very complex set of organisms, and we really don't know at this point in time what's an ideal microbiome, and interfering with the composition of the microbiome could possibly have good effects or bad effects. There's some suspicion, and there have been some articles, that taking fiber to increase the diversity of the microbiome may be of some value. That's about all I can say. My guess is that the fiber you're taking helps control overeating because it makes you feel full. What does it mean when no matter how much insulin I inject, my blood glucose doesn't go down? Well, one possibility is that the insulin is spoiled. It could have been frozen or exposed to heat. If you use insulin syringes and reuse the same syringe, you can deactivate the insulin. I explain this in my book. So unless you use the special tricks that I describe for reusing insulin syringes, you're going to make the insulin inactive. That's one possibility. Another possibility is if you use insulin pens. Many of the insulin pens have needles that are of such fine gauge that the insulin polymerizes in the needle and blocks further injection, so that you think you're injecting insulin, but you're getting nothing. And this is very commonplace. I think it's important to know about this. So I wouldn't use a needle with 32 gauge. I would not use 32 gauge needles on an insulin pen. I've seen a lot of trouble with those. Furthermore, there are very short needles being sold for insulin pens, and the insulin leaks at the injection site. So you may, if you inject through clothing, you could feel the clothing getting wet. Or if you inject into bare skin, after the injection, you rub the skin with your hand. If it feels wet, it means that the pen has leaked because the needle was too short. So I find that probably the safest needles for the insulin pens are the 30 or 31 gauge 12.7 millimeter needles. And those must be replaced every few injections because they can eventually get dull. Now, another possibility is that you're following a high carbohydrate diet and your carbohydrate is way ahead of the insulin that you're injecting. If you're following ADA guidelines, that's commonly a problem. Next question. Can you get nutrient deficiencies by taking some medications? Well, I do know that Metformin can cause malabsorption of vitamin B12. It blocks certain receptors in the intestines, and it doesn't cause B12 malabsorption in everyone, but can do it in some people. Why only some people, I don't know. And how do we check for this? Anytime I start a patient on Metformin, I 3 months and 6 months later recheck their serum B12 level, but also their serum homocysteine and methylmalonic acid levels, because the B12 that you measure in the blood is not indicative of the B12 that's stored throughout the body. So a better indicator of B12 absorption is homocysteine and methylmalonic acid. And I actually saw one person who had hair loss due to B12 malabsorption. So this is a potential problem. I don't know if there are any other deficiencies that cause complications. What is your opinion of a drug called Trulicity? That is the once-a-week GLP-1 agonist. And as I said, I'm experimenting with it. The only people I'm trying it on is people who, after months, became tolerant of Victoza, then of Byetta, and then of amylin. And rather than going back to trying, let's say, the Victoza again, I'm trying the Trulicity to see whether it will work on people who are already tolerant to other GLP-1 agonists. What do you think? No, why do you think that generic metformin is inferior to brand name glucophage? Well, I've answered this before, but it's worth answering again. I was probably the first physician to use glucophage or metformin in the USA. We got it from Canada at least 5 years before it and I consider it a very valuable agent. All of a sudden, maybe 10 years ago, I start getting phone calls from patients all around the country. Why are my blood sugars going sky high? And in each case, it was a patient who had been taking glucophage, and their local physicians had received a notice from insurance companies saying that you can get metformin much cheaper if you change your prescriptions to allow the new generic formulations. So glucophage was off patent and now available generically, and all my patients were having high blood sugars. That turned me off the generic. Now, are there generic metformins being made today that are as potent as glucophage? I don't know. I'm reluctant to take a chance and prescribe them, certainly without at least getting a chance to compare them to the glucophage. So I start patients on glucophage, and if they were to complain about the cost, which hasn't happened yet, I would allow them to try generic and see what happens to their blood sugars. So I'm not absolutely certain that all generics are inferior, but it could well be. And that could have something to do with the binding agent, other things other than the actual metformin itself. Why would one's fasting blood sugar be 120 to 140 and post meals be within the normal range? What can a person do to reduce the fasting blood sugar? Well, this is really answered in the book, and it probably relates to the dawn phenomenon. And this person may need insulin, or may need a long-acting agent like metformin at bedtime, may need Tresiba at bedtime. I don't know. But, or the person may be having a large dinner and have gastroparesis, and the blood sugar doesn't rise rapidly after dinner, but the food is digested overnight while they're sleeping, and they wake up with a high blood sugar. That's another possibility. These things are covered in my book, Diabetes Solution. Glucose was probably 250 to 300 for a long time before diagnosis, with no neuropathy, and now neuropathy when glucose levels are controlled under 140. The question, this person doesn't ask a question. He probably wants to know, why is it that he didn't have neuropathy before but has it now? Well, first of all, blood sugars of 140 are not normal. They're almost double normal. But one form of neuropathy is numbness. And you may not realize that your feet are numb or relatively insensitive to pain. And then when you normalize blood sugars, that neuropathy reverses, and as the nerves resprout, there can be severe pain. And again, we talk about this in my book, the resprouting pain associated with prior numbness. So that's one possibility. Now that glucophage is no longer manufactured, how can I get the best quality metformin? Well, it is manufactured. This is misinformation. And indeed, some of the pharmacies have been misinforming their patients because their distributors may have stopped selling the metformin. Only certain sizes are available. The glucophage XR, the long-acting, is available in 500 milligrams, which is the most convenient size to use anyway. And the rapid-acting has been cut back to only one size, 850 milligrams. Now, although you cannot cut in half, or should not cut in half, the long-acting pills, because the coating is what slows down the action. The rapid-acting glucophage can be cut in half. So if you cut it in half with a pill cutter, that 850 becomes 425, which is reasonably close to 500 milligrams. So this patient has been misinformed. Your thoughts on the Freestyle Libre continuous glucose meter as composed to the Dexcom? The main difference is that the Freestyle does not have the follower app, which is a very important app for many people, certainly for children and for the elderly. And this is the app wherein the user's iPhone transmits their blood sugars to as many other iPhones as they desire. So you could have your wife, your mother, your secretary, your girlfriend, etc., all seeing your blood sugar and getting the same warnings that you're getting if you use the Dexcom system. But you can't do that with the Freestyle system. One other problem, however, is that if you want Medicare to pay for the Dexcom system, you have to use a version that disables the follower app. One wonders whether there's some payoffs somewhere that at the FDA end of things where they have banned the follower app for Medicare patients, who are the patients very much in need of a follower. This is part of the many screw-ups that happen in modern medicine. and many of these are due to bribery. Now, I usually don't answer long questions, but apparently I decided I'd be willing to read this long one. Type 1, diagnosed 5.5 years ago, closely following your program. Last A1C is 4.3. Recently diagnosed with invasive squamous cell carcinoma, which normally is treated with chemoradiation. Given the usual treatment side effects of nausea, vomiting, diarrhea, and loss of appetite, do you have any recommendations on how to handle mealtime insulin doses? Seems like using post-meal Novolog based on what actually gets eaten, or should say digested, could be preferable to constantly trying to treat hypos from pre-meal injections. Well, first of all, I would recommend that you reread the section of my book, which I think is a whole chapter dealing with gastroparesis. We find that certain drugs used to treat the nausea associated with chemotherapy are effective in treating gastroparesis. And of course, the reverse would be true. So there's Zofran, which is used to prevent the nausea of chemotherapy, which we recommend very highly. You probably would require about, I believe it's 8 milligrams, about 2 hours, an hour and a half before the chemotherapy begins. But the dose is really experimental. You play around to see what dose will prevent the nausea. And another product is the one that's sold to around the world to prevent gastroparesis, and that is Motilium. Motilium is available in Canada and in most countries around the world. It was never, the manufacturer never applied to the FDA for approval of Motilium because the manufacturer also makes Reglan, which is the principal drug used in the USA to treat gastroparesis. Unfortunately, Reglan has some very severe adverse effects that can eventually, if you're taking it chronically, can affect almost everybody who takes it. And they're neurologic side effects, including depression. I don't recommend Reglan. There are gastroenterologists who are authorized to have compounding chemists make Motilium for them in the USA. The generic name for Motilium is domperidone, D-O-M-P-E-R-I-D-O-N-E. So domperidone, Motilium are more effective than the Zofran, and these can prevent the nausea. Now, diarrhea is another story, and what I've heard is that usually the problem with the chemotherapy is nausea. If that's the case, these two drugs in advance might allow you to take your insulin before a meal, but it's all trial and error. As a last resort, if neither of these drugs work, your idea of taking Novolog after the fact might be a good idea. I am a 59-year-old female who has been insulin resistant diabetic for 20 years. I'm trying to figure out what this patient wants. Is it possible to cure my insulin resistance? Well, I would point out several things. Number one, you could have polycystic ovarian syndrome. And if that's the case, you can read about it in my book, Diabetes Solution. There are some medications that treat it. If you're overweight, then if you have abdominal obesity, losing the weight can lower the insulin resistance. So we go over weight loss in the book also. That's really all I could think of. Wait, I should also add that Metformin can lower insulin resistance, particular glucophage, also Avandia, and also Actos. I prefer the Avandia to the Actos because I've seen more fluid retention from the Actos, even though the literature says that Avandia causes more fluid retention. Is the autoimmune protocol diet, AIP diet, or the paleo diet also a useful approach as long as your no-no list is followed? As I warned earlier in this teleseminar, beware of paleo diets and any other magical solutions, ketogenic diets, anything that deprives you of protein is hazardous. Furthermore, there have been paleo diets and autoimmune diets that advocate sweet foods, even fruits that have large sugar content. So you have to be aware of these things. I'd say go by my book and don't search for new things. 50-year-old male with type 1 for at least for the last 40 years. So this guy is a survivor. I've followed your carb diet for 2 years. My A1C has dropped from 6.2% to 5%. During the same time, I stopped high-dose lovastatin, but my cholesterol levels have skyrocketed. Well, the person is asking why has his cholesterol gone up? Well, the high-dose lovastatin was keeping it down, but it may not have been keeping down the culprit, which would be high-density, small particle LDL. And what we find is with a low-carb diet, the particle size increases to the more benevolent LDL, the large buoyant LDL. So what you might look at is your LDL particle size, not your total cholesterol. He says also that his triglycerides have dropped dramatically and his HDL has increased. So in all likelihood, what has happened is the lipid profile has improved. If you're worried about cardiac risk, you should be looking at things like the coronary artery calcium score and signs of inflammation like C-reactive protein and other tests that measure inflammation. The total LDL or total cholesterol are not at all good indicators. In fact, they've been abandoned as indicators. Is it true you inverted the basal bolus method and, that you invented the basal bolus method? And if so, why has this been so readily accepted by the medical community? Well, yes, it's true that I invented it back around 1969 to 1970, and it was not accepted. It was ridiculed. In fact, I have a letter from the editor of the New England Journal of Medicine ridiculing it. And my own physician, who was president of the ADA, said, it's hard enough to get a patient to take one shot of insulin a day. How can you expect me to teach them to take multiple shots? And it was ridiculed, as was blood sugar self-monitoring, for about 10 years. And then it was really patient demand that brought about a change. So these benevolent changes were not accepted by the medical community. And that's why I had to go to medical school, because I couldn't get published. All the publishers rejected what I submitted. How does menopause affect a woman with type 1 diabetes, and how are we to handle it? Well, the effects vary greatly from person to person. Sometimes it's helpful to give glucophage XR, that's the time-release glucophage. Sometimes it's helpful to give DHEA. Sometimes it's helpful to give estrogen. You could see a reproductive endocrinologist, and it's a matter of trial and error with all these experiments to see what helps the blood sugars. Usually what we see is after the periods stop, we get more stable blood sugars. Many women have unstable blood sugars when they're having periods prior to menopause. For example, 1 month they may go up for a week prior to menses. Next month they may go down the week prior. Some women always have the same thing every month. They always go up or they always go down. So there are problems associated with menses that are usually not associated with menopause. But if there are new problems, see a reproductive endocrinologist. If you can't find a reproductive endocrinologist, or you live in an area where there are none, you can ask your gynecologist to experiment. Is there a formula for regulating the amount of basal insulin delivery? I take a pump during the transition, insulin delivery. I take via pump during the transition to achieving ketogenesis. Number one, I don't recommend pumps. You should read my book, Diabetes Solution. I've never seen a well-controlled diabetic using a pump for more than 2 or 3 years. You just can't get blood sugar control. I don't recommend ketogenesis, because usually these people are protein deprived. So I think you're on the wrong track. I suggest you read my book, Diabetes. For the past 4 days on low-carb diet, I have lost energy. My muscles ache and my energy level is low enough that I feel like I need to be in bed. How long does it take to completely transition over to complete fat burning for energy? What can I do to achieve this quickly? Well, my guess is that this person, again, is doing what I keep warning about. The person has increased his fat intake and lowered his protein intake. His muscles are now deprived of protein. That's one possibility. And I've seen the cases of this clinic. The other possibility is that the patient is not measuring blood sugars and has and maybe taking medication for blood sugar treatment, and was having elevated blood sugars before, and now they're lower, maybe even so low that he's getting hypoglycemic, or she. So it could be that these are symptoms of hypoglycemia, very possible. Furthermore, people who have very high blood sugars and come down lower without even being normal will get symptoms of hypoglycemia. And that's all discussed in my book. So you could have an average blood sugar of 250 and bring it down to 170 and get symptoms of hypoglycemia. So as you can see from the questions, this business of getting muscle breakdown from protein deprivation is fairly common. I'm a type 1 for 23 years. Is it possible to improve kidney function and reduce diabetic macular edema? Well, I've seen both reversed in my patients, and I certainly reversed my own advanced kidney disease many years ago. So yeah, now it depends how far advanced the problems are. If your macular edema is so severe that your retina has been really separated from its basal structures, then you're not going to recover your vision. But if the macular edema is early, we usually can reverse it with normal blood sugar. As far as the kidney disease goes, I had 4+ proteinuria every time I urinated. And to be that far advanced, you have to be producing at least 1,500 milligrams of protein in urine a day, which is a lot. And mine is now down to 0. Was 0 the past 50 years. So the normal blood sugars can be. Please explain why the consumption of saturated fats do not increase insulin. Well, it's a sort of a strange question. I'll review what happens in non-diabetics who make insulin. No matter what they eat, it could be pebbles, you will distend the gut, and that will cause the production of GLP-1, which causes the production of insulin by the beta cells, and also indirectly the production of glucagon by the alpha cells, so that if you're just having fat or pebbles, your blood sugar ends up normal. But you are making insulin. Doesn't matter whether it's saturated fat or unsaturated fat. So I would suggest that if you want to learn about this, you read my book, and it does discuss this. Well, we finished for today's teleseminar. The next teleseminar will be April 25, 2018 on a Wednesday. Please join me then. Thanks for listening and watching today.